I'm glad you guys made it. I thought everybody was going into retina now and nobody cared about cataract surgery anymore, but apparently not. So good morning. I'm Dr. Mark Pfeiffer from the CPEC service, and this is a lecture from your core series. So it's based on chapters, loosely based on chapters from your BSCS book, Cataract Surgery in Special Situations or in Challenging Situations. So the outline of what we're going to talk about today, there's various considerations that can make cataract surgery more challenging. And our goal is to make it as simple as possible, as predictable as possible to get good outcomes. So we'll talk about psychosocial considerations, systemic diseases, and primarily ocular diseases that can make cataract surgery a little more difficult or challenging and how we can manage those. The sources for the lecture are primarily your Academy BCSC Book 11, the Cataract, Lens and Cataract book, and Chapter 10 is the book on complex cataract surgery. A couple other items I've taken from the Academy Focal Points module by Warren Hill on complex axial length measurement and IOL power calculations. Dr. Hill has a website that has a lot of good formulas and useful tools on there. And some videos I've gotten from, and this is kind of old now, phacopearls.com has video, but now you can find cataract surgery on YouTube. So there's tons of video out there, lots of things to look at on people's techniques. And so, you know, this is an unpredictable and kind of a dangerous activity, right? And we don't want cataract surgery to be like that. We don't want, challenging cataract surgery should not be like swimming with sharks. We want to make it predictable and safe as much as possible. So the psychosocial considerations first. Dementia or mental disabilities, you really need to identify this preoperatively. And sometimes it's hard. If you're in a busy clinic and one of the giveaways a lot of times is the patient really doesn't answer questions that their son or daughter does. You have mom there and she's in for cataract surgery and you say, are you having any trouble? And the daughter says, yes, she can't read. And, oh, okay. Well, then you look at the exam. Well, you have a cataract. Do you want to be set for near and continue to read without glasses or distance? The daughter says, mom likes to read. Why don't you just leave her set for near? If you're not getting much response, sometimes that's an indication maybe she doesn't really understand. So take a moment to think about and assess the patient's own kind of mental status and their ability to cooperate. Because cooperation is required. We do most of our surgery under topical anesthesia with sedation. And the patients have to lie still for surgery for it to be safe. So we want to avoid combativeness or uncontrolled movements. Patients with dementia that can seem very oriented in a normal situation can suddenly become very disoriented and even combative. And has anybody been in that situation in cataract surgery where the patient all of a sudden, you really can't communicate. It happens quite frequently. They get a little too sedated, they go to sleep for a while, wake up, and then they don't know where they are, they start fighting you, and it makes the surgery very difficult and potentially dangerous. So sometimes it's better to under-sedate people with situations like that and just keep them calm, but at least you're thinking ahead of time, and that's important. Claustrophobia can happen. The position of the drape, CO2 buildup under the drape is an issue for patients with COPD. And related issues with movement and cooperation, coughing, hiccups, snoring, breathing, obese patients or patients with sleep apnea when they're laying flat, all of a sudden they obstruct a little bit and you get this heaving, breathing motion. Has anybody been in that situation? Right? You're trying to upright. The breathing, the patient's going back and forth, and anesthesia says, I can't sedate them anymore because they're going to stop breathing, but if they wake up, they'll be moving around. So you're kind of stuck in that situation. It's important to predict, and there are ways to manage it. One innovative tool, and this I've never used, but I thought it looked interesting, I took that offline, is Nevius, Dr. Nevius, who's in the community here, drape retractor. That you can actually buy this. It's a little sticky thing that keeps the drape up off the patient's face. There are other things that anesthesiologists have come up with that I work with. Just something a little like a light plastic box that you'd save from the packaging or something that you can put on the patient's chest right under the chin and elevate the drape, or tape it to the Mayo stand. Keep the drape up off their face. It helps clear the CO2 and also helps prevent claustrophobia. So involve the anesthetist. That's what's important, whether it's a nurse anesthetist or anesthesiologist. Make sure they're involved in your planning and they understand how still you need the patient and what the situation is. We talked about sedation levels, sometimes better to less than more, but it really helps to have a good anesthetist. I mean, you can't underestimate how important it is to have someone who can titrate what they're giving the patient in response to how they're acting and what you're doing. You run into trouble, the case you need a little more time, the patient's getting a little restless. You can keep them, you can drop topical anesthesia on and keep them comfortable, but you can't improve their cooperation if you don't have good anesthesia. So positioning is important to avoid this Valsalva type obstruction. I always like to put the feet down so that you're a little bit of I guess that's reverse Trendelenburg, right, with the feet lower than the head. As long as the head's flat, patients are always worried, oh, you're going to make me lay flat. So they don't like being all the way flat, too. If you can keep the head relatively flat, the body can still be tilted, almost in a seated position sometimes. So, and even consider general anesthesia. Oh, IV narcotics or lidocaine for a cough. If a patient's coughing, they can give them something to suppress it. Both of those things, IV will help. And don't be hesitant to consider general anesthesia if you really need it, or something that they call TIVA, total IV anesthesia, like a propofol drip. If you really need the patient still and there's no other way and they're worried about the airway, most anesthesiologists will be more comfortable putting an LMA in and saying, we're going to control the airway, let's just have this patient go to sleep, even if it's a short procedure. It's worth it for safety if you need to. Communication problems, hearing disabled, allow the patients to wear their hearing aids so you can talk to them. They can't see you, they don't know what's going on, they hear strange noises, they feel things. If they can't hear you telling them it's okay, you're fine, they can get very disoriented or combative. Non-English speaking, I usually have a translator give instructions in the pre-op area. That little pep talk you give them right before you go back, here's what to expect, you're going to see a bright light, I need you to hold still, just look at the light, you'll feel some fluid, but we'll keep you comfortable, and the procedure will be about 15 minutes or whatever you normally tell them. That's important to tell someone, and if they don't speak your language, they might be nervous. So if you have someone there to translate that little talk, it's much better before you sedate them. Patients who English is a second language forget the English once they're sedated. You've probably seen that happen too. So it's important for you to learn certain words. I always ask, if they actually absolutely speak no English, tell me what's the word for light, or everyone understands okay. So if I say okay, it means it's fine, or if I say no, it means don't move. So you have their relative who speaks their language explain to them, if I say no, that means stop doing what you're doing, and light, look at the light. Just a couple of things. And consider this, the book says this, I've never done it. Consider inviting the relative in there as a translator into the OR for special cases. If you really need to communicate, that might be necessary. Local block is important, does not improve patient cooperation. Sometimes anesthesia will say, you got to block this patient. I think they're not going to be cooperative, you got to block them. Well, block is good if you think you're going to have a prolonged case and you need good anesthesia. They often become uncooperative if they're in pain. But if you can keep a patient comfortable, blocking will not improve someone who's going to be uncooperative for other reasons. So don't hesitate, again, to recommend general anesthesia for different categories of patients. Young patients or very nervous patients. Older patients tend to be a little more calm. Maybe they've already had medical procedures. They're a little more comfortable with having surgery, as opposed to a very young patient, a teenager, 20-something, very anxious, very nervous, hard to keep still, maybe hard to sedate sometimes. So Alzheimer's, dementia we mentioned, other mental limiting conditions, Down syndrome, autism, profound deafness. I had a patient completely deaf from birth, sign language only, was very comfortable in the office, but communicates with their eyes, right? So when you have you're working on one eye, the bad eye, right? The good eye is covered. They can't see you. They don't know what's going on. Very, very nervous, asking a lot of questions. Finally, I said, would you rather be asleep? And they said yes. So even though it's a routine 10-minute case, that was much better for this patient. No more anxiety, and everything was fine. They would rather not be unable to see and not know what's going on and be aware of anything. Or certainly prolonged procedures, combined surgery after trauma, if you expect excessive manipulation, if you're going to have to suture a lens in or do some other maneuvers, those are cases that you might, if it's prolonged, maybe general anesthesia is safer, because patient safety is our primary concern. That's really what we're after. It's not say, oh, I did this case under topical in 10 minutes. You want a safe and predictable outcome. The time to put out the kitchen fire is not by the time it gets like this and you're throwing buckets of water from the window, the living room window, trying to put out the fire next door. We want to predict a problem before it occurs and control the situation. So systemic diseases, considerations, coagulopathy, anticoagulation. We always prefer topical clear corneal incision. These days, you guys probably, and I do it too, you probably even forget to ask, because we're going to do clear corneal surgery. We're not giving retrobulbar or peribulbar anesthesia. So you don't even worry about anticoagulation. Aspirin, Coumadin, the newer agents, the other anticoagulants that are popular now, you need to be aware of that. And if you're going to block, they need to stop it, because what's the main risk of retrobulbar or peribulbar blocks? What's the most common complication? Anybody? Hitting the optic nerve? No? What is it? Retrobulbar hemorrhage, right. And that's fairly common. And patients that are anticoagulated, primarily antiplatelet agents, aspirin, Plavix. They need to be off those for about a week usually because the risk is higher of a retrobulbar hemorrhage with those agents really even than Coumadin. So about 3 days for Coumadin, longer than that for antiplatelet agents. Avoid intraoperative or iris or uveal trauma because it'll bleed more. You'll get a hyphema potentially. Put the IOL in the bag because any UGG syndrome, right? If the patient's anticoagulated, they're much more common to have recurrent hemorrhages from irritation of the uvea by the IOL if it's not positioned properly. COPD, positioning, again, we talked about for breathing, coughing, respiratory depression. You have to consider those issues. Arthritis or kyphoscoliosis, the patients in the chair, they have trouble getting in the slit lamp, but you can examine them. What happens when they lay down? Positioning and comfort are important, but here's a patient with ankylosing spondylitis, very severe. That's as far flat as he could lay. That's it. The neck was rigid like a stone. Could not turn the head, could not lay any flatter. That's as far back as he could go. Yes, we could put the feet way up in the air, and some people have talked about doing that and try to get the head flat. But what we decided to do is do the surgery basically sitting up. As long as your microscope tilts and you work from the side, I basically did the case with the patient pretty much upright, and it works. You really don't need gravity to do successful cataract surgery, phaco surgery, if you have a sealed system, a sealed chamber. And there is a gentleman, and I think it was Dick McCool in New York, who showed a video of upright face-to-face surgery. He actually put a bench over the patient's lap and basically sat on the patient's lap and operated sitting upright. So it's not the preferred way of doing things, and this was a little tough on my neck, but the surgery went well. So that's another issue you might have to deal with. Diabetes, medical clearance, cardiac and renal disease, you need to consider those and their effect on anesthesia or the drugs you might give. Careful retinal evaluation as always, make sure there's no retinopathy or it's controlled, or signs of ischemia, at least to predict, are these patients who are going to get worse after surgery? Do you need that controlled? Diabetics, you need to consider blood sugar. The patients are fasting overnight, right? So if an oral agent, the usual rule is hold the morning dose because you don't want their sugar to drop low. They're not eating. For insulin, if it's short-acting, usually it's to take half of their morning dose, but involve the primary doctor. If you have somebody good here, I know Dr. Coca does this for you guys, or their primary doc, they should help tell them what to do with their insulin or their diabetic medications if they're fasting for 12 hours or more. You always prefer acrylic lenses in the bag, especially if there's a need potentially later for a vitrectomy with silicone oil, because silicone interacts with silicone lenses and you get bubbles and fogging. That people ignore that now because not as many people are using silicone lenses, but there are a few. The crystal lens is silicone. Some of the three-piece lenses are silicone. Most of the one-piece lenses, foldable lenses you guys are using now and that I use all the time are acrylic, so it's not as much of an issue. And the usual guidelines in diabetics, small incision, large optic lens in the bag, meticulous cortical cleanup. Those things are even more important because any residual inflammation will increase the risk for what's the most common vision-threatening complication after cataract surgery in a diabetic or anybody. What do you think? Anybody? What's that? Anybody? Seniors? What are you looking for if their vision drops 3-6 weeks after surgery? Macular edema, right. Cystoid macular edema, and that can be very difficult to treat. You're much better off preventing it. Inflammation that is not well controlled is the biggest risk for CME in addition to ischemia. So the vessels are already compromised, the capillaries aren't, non-perfusion or poor perfusion. That increases the risk for CME. The inflammation is greater. So if you don't get rid of all the cortex or you have any kind of uveal irritation that's chronic, creating a chronic uveitis or iritis, those patients are much more prone. Even normal eyes are more prone to get CME, but especially diabetics, and it can be very hard to treat, hard to control. Wound healing issues in diabetics as well as others, elderly, debilitated, chronic steroid or immune suppression treatment, there may be difficulties in healing. This was, again, more of an issue when we were making large incisions, which everybody probably, it's a lost art doing a planned extra cap anymore, but even a small incision without stitches, you can have leak and issues of wound melts. Rheumatoid arthritis, polymyalgia, chronic uveitis, organ transplants, renal failure, anyone who may have difficulty with healing or his own immune suppression. They're prone to wound dehiscence, corneal scleral melts, larger astigmatic shifts if you do have to suture a wound or leave make a larger incision. So a small incision is always preferred in those patients and just about everybody, but if you do have to place sutures, leave them in a little bit longer and expect to have some issues with wound dehiscence potentially even later. And epithelial problems are a big one, and that's still present with clear corneal incisions, and maybe even more so. We may be inducing a little bit more neurotrophic effect. So if someone has pre-existing reasons to be neurotrophic, that can cause issues with wound healing, corneal, loss of corneal sensation. What do you think that is, anybody? And it looks like a herpetic ulcer or something, right? That's actually a geographic ulcer from neurotrophic cornea induced by nonsteroidals. And nonsteroidals are great for preventing macular edema, and almost everybody uses them postoperatively, or you'll certainly use them to treat CME if it occurs, but they can also cause melting, so be very careful, or at least epithelial problems and problems with healing. So we have to be very careful with topical nonsteroidals in patients with dry eye or compromised epithelium, and look for something like this, or even earlier. You don't want to wait till it gets to this point. You'd rather catch the confluent SPK or signs of bad epithelium. Get them off the nonsteroidal. Don't just say, oh, your eye's dry, use some tears. If you're using Cataract, which is the generic most people use, or any branded nonsteroidal, even the newer once-a-day agents, they do cause somewhat of an anesthetic cornea and can cause problems with healing. We don't know if it's neurotrophic or matrix metalloproteinase induction mechanism, but a combination of the two can cause problems. And it's not just generic diclofenac. This was a big problem. They took it off the market years ago, but it was connected with the preservative. Any nonsteroidal can do this, and you have to be careful. Ocular external diseases should really be controlled. What does the guy on the top have? You can make this diagnosis from the door. What is that? Anybody? Yell it out. Rosacea, yeah, facial rosacea. It's plainly obvious. Rosacea patients often have very bad blepharitis. The rosacea is usually not this obvious, but if it is, expect to have problems with the meibomian glands and with the ocular surface. So blepharitis, rosacea, dry eye syndrome are kind of a continuum. They're all together. You need to optimize the ocular surface before surgery, not only to get good measurements, because our results are critically dependent on getting good K readings. Good axial length probably isn't dependent on the cornea as much, but corneal curvature readings are important for visibility during surgery and for patients' vision after surgery and for good healing. So anyone with an ocular surface problem or chronic blepharitis, you treat it ahead of time, get it better. Even if they have a bad cataract, they're begging you to take it out. Doc, I can't see. You got to take this cataract out. It's worth waiting a couple of weeks at least to get them better. And the usual treatments for blepharitis that we talk about, warm compresses, lid hygiene, antibiotic ointment, frequent tears, restasis, cyclosporin works very well. Oral doxycycline or omega-3 fatty acid supplements, fish oil, punctal occlusion, but not when there's inflammation. Punctal occlusion comes later after you've treated the blepharitis and inflammation. If they're tear aqueous deficient, punctal occlusion helps. Pre-op antibiotic prophylaxis, that's basically now the community standard of care. Most of us, almost everybody, and you guys are doing it in the clinic, I know, starting antibiotics a few days before, because patients with lid disease, or any patient, but especially if they have lid disease, can harbor chronic infections, staph bacteria that are maybe resistant, and they're more prone to endophthalmitis. So there's a reason to kind of clean up the lids ahead of time, not just for good vision and good measurements, but to prevent the rare case of endophthalmitis. And again, the usual guidelines in these patients: small incision, good lash isolation, drape the lids very well, and post-op watch for the corneal epithelial problems and stromal melts in patients with bad surface disease or are prone to surface disease. There are other more subtle corneal conditions that can affect you, and it's hard to see in this photo because it's a little blurry, but that's actually taken from the book. What if, in broad side illumination you see these little bumps in the cornea or something? What's the most common condition on the surface of the eye that might cause a problem? Anybody yell at that? What are they trying to show on here? It's basement membrane dystrophy. Very common. I'm not even sure it's a disease. It's probably more of a degeneration. Comes from chronic dry eye, chronic inflammation, probably sunlight exposure. There's a hereditary factor, but even often just age. Patients have recurrent erosions. They come in, right? They wake up in the morning with pain in the eye. By the time they get into your office, everything looks fine, but if you use a broad beam from the side or a little retro illumination on the slit lamp, you'll see these map dot fingerprint, lines and whorls in the cornea. There are defects in basement membrane and irregularities that cause problems with epithelial adhesion, but those lumps and bumps and hills and valley in the cornea distort the vision too. So it's important to differentiate the visual effect of the cornea versus the cataract in patients with corneal problems. And a very subtle issue centrally can really create significant distortion in the vision. And there are ways of trying to separate those two. A contact lens, put an RGP contact lens on and refract over top. 2200 best corrected vision might be 20/30 when you get rid of the irregular cornea effect. Keratometry and topography is very helpful. I get topography on everybody, and I think you guys should get it more and more now that I think we have all the instrumentation conveniently available in the CPEC. And certainly any patient you're going to do a toric lens or treat astigmatism, you have to have topography. But I've gotten to the point where I like to have it on everybody because you find things you weren't aware of. And the old rule, the adage is, if you find it before surgery, it's the patient's problem. If you find it after surgery, it's your problem. So if you operated on the patient telling them you're going to see great, and they don't see great, and then you say, oh, well, you have this cornea problem, it has nothing to do with my surgery, they don't believe you. You know, I had a cataract, you told me I'd see fine, why are you now telling me I have some other condition? So find it ahead of time and tell them about it. Even if you don't treat it, just say, you have this condition, it might limit your vision after surgery. If we have to, we'll do something later. Let's get the cataract out. Now, there are things you can do beforehand. For ABMD especially, debridement or phototherapeutic keratectomy with the excimer laser. That's expensive and not often covered by insurance, but just simple manual debridement or with a diamond burr, polish off the irregular epithelium and then heal with a bandaged contact lens or even an amniotic membrane device to smooth out the cornea. It really helps. So if you can regularize the topography ahead of time, it's helpful. Even just treating with lubrication and ointments and so forth. Scars, opacities, a small Saltzman's nodule in the periphery that you think, oh, that's not visually significant, can often cause very significant irregularity in the surface of the cornea, or keratoconus, obviously, which is not always obvious on the slit lamp exam, but can be on the topography and is. So this is why topography is so important. The cornea might look normal to you, but I mean, the thing that hands it to you, right? This is the little analysis program. I don't have to ask you what that is, but tell me what just looking at the topography, what is the diagnosis? If it's not just simply keratoconus, what do you call that? Anybody? Pellucid marginal degeneration, right, I heard. That's the classic crab claw. You know, the red is where the cornea is steeper. Yeah, go ahead. I meant to tell you, interrupt me with questions.
What's your thought about toric lenses and keratoconus?
You have to be careful, but a patient like this, if it's been stable, usually older patients have stopped changing. They sort of auto cross-link the cornea. You know, you hear about cross-linking. That's a way to stiffen the cornea. Cross-linking occurs naturally just with sunlight exposure and age. So the cornea stiffens over time and keratoconus stops progressing. If this patient is over 65 and this has been pretty stable and their refraction matches, you see the central, that black line, yeah, I guess you can't see my pointer, but the black circle in the center, I don't have a pointer, is the pupil outline.
Your mouse arrow.
Oh, you can?
Yeah.
Oh, okay. That's the pupil. So, and that's taken with before dilation, obviously, but if you look right within the pupil, that looks like fairly regular astigmatism. It's irregular down here, and so there may be some limitation, but if this patient, like, I'd have to calculate here, where are the Ks? I don't see the reference toric 48 by 50. So it looks like maybe about 2 diopters at 4 degrees. Do you see that down here? That's the simulated K readings. So it's a steep cornea to begin with, and that tells you it's probably abnormal. But if you get a fairly regular looking astigmatism centrally and it matches the K readings, the keratometry readings, and it's been stable, it's reasonable to consider a toric lens. But not if they're going to wear a contact lens. If they're wearing an RGP contact lens, then you'll have to undo the astigmatism you just induced with the toric lens, if you know what I mean, or if they're going to have a PK. If you forget it there. But if it's stable and you don't think they're going to need graft, then it's reasonable to use a toric lens. And I've gotten good results. Undercorrect a little bit, you know.
An aura?
It might be helpful, and that's one of the things I'm going to mention later. Although it's not people say, oh yeah, aura for everything, but you still have to take it with a grain of salt. You can get spurious readings with the aura because of intraoperative changes in the cornea. So it is a little helpful, but if it doesn't agree with your pre-op measurements, go with your pre-op measurements. Endothelial dystrophy, another consideration. Look carefully for gottata, pigment, stromal edema. Cataract surgery is usually acceptable, even in Fuchs, if the pachymetry is less than 600 or the cell count is greater than 1,200 cells per square millimeter. So they're kind of our rough rules of thumb. Obviously, if a patient starts out with a thin cornea anyway, you could, if they have a 500 micron cornea that swells to 580, that's, it's still under 600, but they might have significant Fuchs. But if you didn't know anything about their cornea ahead of time, usually we look at those parameters and say it should survive surgery without needing a graft. Nowadays with DSEC, It's much less of a big deal to have a corneal transplant. So I will tell patients we're going to protect the cornea as well as we can, maybe use a femtosecond laser. And this femto is not part of this lecture really, but, I use femtosecond a lot, but I don't think it's for complex cases. Some people say, oh, use femto on any difficult case. Not necessarily, but it does allow you to use less phaco power, and that may be a little bit, and there have been studies showing less corneal endothelial cell loss in experienced surgeons' hands between femto-assisted surgery versus strict manual surgery. And it's mainly because of the reduction in ultrasound power that you have to use to break up the lens. So you want to protect the endothelium your best way possible. Dispersive viscoelastic, Viscoat, Heal-On 5, minimize phaco power, minimize fluid flow, and work as deep as you can within the eye. Deep in the bag, don't kind of pull up in close to the endothelium. That's true in any case, but especially in patients with a fragile endothelium. Prior corneal surgery is an issue, post-penetrating keratoplasty. There's an increased risk of graft failure after surgery, so you want to wait till the sutures are out, the refractive condition is stable. And we consider triple procedures, but the IOL calculation is very difficult because you really don't know what the corneal curvature is going to be afterwards. Cataract post-RK, we don't see as many of these patients anymore, but they have a early hyperopic shift. The old radial keratotomy, the cornea is weakened, they're prone to sort of a controlled ectasia almost. IOL calculations are challenging. Always aim for a little myopia to avoid the hyperopic surprise. And there are methods to do this that I won't get into, but you can use a contact lens over refraction to kind of estimate the true corneal curvature because your K readings are way off. That's the problem with refractive surgery, that the anterior curvature readings that you that you take are not predictive of the lens power you need for a couple of reasons. One is in laser vision correction, you've flattened, excimer laser, you flattened the anterior cornea, but really haven't changed the posterior corneal surface. So the ratio of anterior to posterior is different, whereas standard formulas assume a standard ratio. We don't really measure the posterior cornea. We're paying a lot more attention to it now. There are some devices that measure it. That's a little out of the scope of this lecture too, but Doug Koch from Houston has a Baylor nomogram that's very useful in estimating the average posterior corneal curvature and accounting for it. The rough rule of thumb is you want to overcorrect against the rule astigmatism, horizontal, and undercorrect with the rule, because the posterior cornea adds some against the rule astigmatism. So if you're trying to correct with the rule and you're already partially corrected by the posterior surface, you'll overcorrect them. And the other reason is you drift from with the rule to against the rule with age. So if a patient has vertical astigmatism, leave them with half a diopter. It's better because they'll gradually drift to plano, and chances are the posterior cornea is neutralizing that anyway. That's another reason the aura is helpful, not necessarily in weird corneas like keratoconus, but in a standard cornea that you don't know the posterior surface, or post-LASIK. And that's where I really use the aura. I have one this morning, actually, that's if you're not sure of the cornea, you don't know what the posterior surface is, the aura lets you measure that because you're basically refracting during surgery, doing a wavefront refraction of the whole eye after the cataract is out. And that lets you take into account the posterior cornea as well. So it's challenging because the anterior cornea has changed, and if you're measuring a 39 diopter cornea in a 27 millimeter eye, that's very unusual in nature. The patient probably started out with a 46 diopter cornea, and it's been flattened to 39 by LASIK. But the corneal curvature is used to predict the effective lens position. And you'll hear about effective lens position. It's basically optically where the lens implant is going to sit within the eye, because the model of what it does and where, how it bends the light depends on its position within the eye. And it's very sensitive to that. The formulas we use predict it. We can't really measure it directly, although there are ways we're working on that can do that. But right now, the formulas predict it based on the size of the eye. And the Holiday 2 that you guys use just uses more information. It uses the white to white, it uses the refraction, the patient's age, to try to increase the accuracy of the effective lens position prediction. But if you've changed the cornea with surgery, you've altered that curvature and the predictions are off. So it's challenging. And the other reason it's challenging, patients have high expectations. If you come out -1, you say, oh, you're just going to wear glasses, you'll be fine. Well, the LASIK patient is used to 20/20 uncorrected vision, and they're often coming to you very soon. They get a PSC cataract that causes glare and drops them to 20/25. They're miserable. They're saying, I can't see. I have patients telling me, I'm blind. Doc, I can't see. Well, you're 20/20. No, but I can't see. It's all blurry. And they have a PSC cataract. It's because they used to have crystal clear vision. So they'll come to you early, and they have high expectations. So we owe it to them to try to get them as close to where they used to be before the cataract as possible, but you have to tamp those expectations down. And despite best efforts, lens exchange may be necessary, and I tell patients this: if we're off the mark, we may have to do something, either a LASIK enhancement later on, which is an option if they have a normal cornea, or a lens exchange if you end up +2 instead of plano. There are various methods. In the book, it talks about this clinical history method. If you have the pre-LASIK measurements, the Ks and their manifest refraction, the basic goal is accurate, effective corneal power. So they may still have an error in effective lens position for what I described, but at least you can estimate the cornea. And aim for a little bit of myopia if you're not sure, -1 to -0.5. There's a whole suite of formulas on the ASCRS website, and they're excellent. And the more information you have, you basically fill out this template, and it'll use, there are like 9 or 10 formulas. It'll give you as many of them as you have information to calculate and show you where that will end up. So you can look at some of the formulas. Many don't need pre-op information, and we're trending more towards ways of doing this without having pre-op information, because most patients don't know. But if you can get the records, it's very helpful. And here's an example of the clinical history method. If the average pre-LASIK K reading was 44.65 and the spherical equivalent refraction was -675, if you vertex that to the corneal plane, it's -624. So that was their pre-op refraction. If the post-LASIK refraction was close to plano, say -1/4, then you calculate the effective post-LASIK corneal power by taking their original corneal power, subtracting out the effect of LASIK to give you an effective corneal power. That number, that 38.66, plugged into your normal formulas, is often better than what you measured, because what you measure varies. The cornea has been reshaped. So if you calculate the theoretical corneal curvature based on their refractive shift, that's a much better way of doing things if you have the information. But the ASCRS website has others. Sam Maskett has a formula that was really based on heuristics, looking at a bunch of patients post-operatively and seeing what kind of adjustments you can make in like a linear predictive fashion, and that's pretty accurate. So if you have no preoperative information, Maskett's formulas and ones like it are good. Glaucoma. We deal with a lot of glaucoma patients. They get cataracts. The question is combined surgery versus phaco alone versus staged procedures. Increasingly, we're doing staged procedures. If someone needs a trab, instead of doing these together, we'll often do the cataract surgery first, clear cornea, get them healed, and then do the trab later, or vice versa. Their pressure's out of control. They have to have the trab. Just do it, get it healed, get it working, because we're not damaging. The old rule was you can't do them combined because you're going to cause problems with the conjunctiva. If you're operating superiorly, you're doing a peritomy, they can't do a trab at that site. But we're operating temporally clear cornea, so everything's changed. You have virgin conjunctiva up under the lid, even after cataract surgery, to do a filtering procedure if you need it, trab or a tube. Avoid post-op spikes. The glaucoma patients are prone to post-op spikes. We have other devices now like iStent, which I use very commonly, which is a kind of a combined procedure, but it's only approved for use during cataract surgery. A little trabecular bypass stent that you can slip in right into the angle. It takes 2 minutes, 5 minutes, right at the end of surgery. Works very well, but it's not a trab. It's not as good as a trab, but it'll help with pressure control. But you can still get post-op spikes, so you want to remove all the viscoelastic. Be extra careful in glaucoma patients. Restart aqueous suppression right away. Patients will often say, you give them a thing, oh, here's your post-op drops. If you're busy, you forget to say the glaucoma drops. They'll always assume, even though they've been on the same glaucoma drops, maybe it's just once a day prostaglandin, for years, they'll stop it and say, well, I thought I wasn't supposed to use it because I'm using all these drops. No, I have it on my instruction sheet. Keep using your glaucoma drops unless otherwise specified. Control inflammation and watch for steroid response. Pressure spikes a week or two later are usually steroid response, not inflammation. If everything looks good, but they formerly were 15 and they're up to 30 and you're using Dorazol, chances are the Dorazol is playing a role. So switch over to a softer steroid like Lotamax, or use a non-steroidal without a steroid if they are prone to glaucoma response. Increased incidence of CME in glaucoma patients. Prostaglandins, I don't really hold them, but there's a question. Some people do. If you think CME is very high risk, like they had CME in the other eye, I would definitely stop the prostaglandin postoperatively and use an aqueous suppressant instead. Weak zonules, you expect that in pseudoexfoliation or chronic miotic use. And posterior synechia. High viscosity dispersive viscoelastics are helpful, like Healon 5 or Viscoat again. Stretching the pupil, doing sphincterotomies, which I don't do as much anymore because of the Malyugin ring or iris hooks. They're a much better way, but this video shows you, this is as far as that patient dilated, which makes it a little more challenging, but there's this device called a Beeler pupil stretcher. It has 3 prongs. You just put it in through your small incision and extend, and then add more viscoelastic, and now you have a stretched pupil, and it's fine. So the stretching creates these little microsphincterotomies. We used to, in some cases, cut it with scissors, and some people may still do that, but that kind of can create a regular pupil margin. So another way is to use iris hooks, which you see here. They used to be called grease hobbers. They're reusable or disposable little hooks that are iris retractors. This video shows how to put iris retractors in. I don't use these as much anymore because of the Malyugin ring, but I think this was made probably before the ring was available. And this pupil is already pretty big, but this may be a case where they were expecting problems with the pupil shrinking down, like floppy iris syndrome that I'll talk to you about. But you can see how you can get the pupil out of the way and the surgery is a little easier. One big thing now, and you all are familiar with this, is consideration of IFIS, intraoperative floppy iris syndrome. It's associated with the use of alpha-adrenergic receptor blockers, primarily Flomax, tamsulosin. But they're less common for Cardora, Hytrin, saw palmetto, but still there. And there's some newer versions of very highly selective alpha blockers like Flomax, tamsulosin. There's one, I forget the name of the other one, but be aware of these medications. And they don't go away. Patients will say, oh, I'll stop my Flomax. That doesn't work. The effect is permanent. It weakens the iris sphincter muscle, even if they took Flomax for a month, a year ago. I'll ask, and sometimes we forget, but my workup technicians know to ask as well. Do you ever take medicine for your prostate? Did you ever take Flomax? And they might say, oh yeah, it made me dizzy and I stopped. But I've had patients, even if they took it for a week, a year ago, they have a floppier iris than I would expect. So you can minimize problems with this, and they might dilate very well. So you look at them in the slit lamp, oh, that's a well-dilated pupil, I'll be fine. You get into surgery, and there's no muscle tone to the iris. Has anybody experienced this during surgery? It starts to flap around, it gets sucked into your aspiration port very easily, it prolapses through the wound, and it can turn a routine case into a very difficult case if you don't expect it and don't control it. So I have my Flomax protocol, and I still use this on every patient on Flomax or if I'm worried about floppy iris syndrome. Pre-op topical atropine the day before, just 3 times the day before and the morning of surgery. Intracameral epinephrine or phenylephrine now, they call it sugarcane, or this epinephrine mixed with lidocaine. Now we have phenylephrine. And high viscosity viscoelastic like Healon 5 or Viscoat to try to tamponade the iris and keep it back. Iris hooks or the expander ring are frequently necessary, but don't stretch the pupil like you saw that maneuver with the pupil stretcher. That just makes it worse. You could stretch the pupil to get it dilated and everything looks great, but you're actually making the floppiness worse and weakening it. So this video, I think this is from one of mine a long time, shows a maximally dilated pupil with pre-op drops in a patient on Flomax, and what I will commonly use now for it, let me see, I might be able to speed this up. Oh yeah, this is just putting in the sugar cane. And you can actually see a little bit you can see the pupil moving on the other side just by putting that in. I don't know if I can make this a little faster. I don't think it lets me advance. So there's a little bit of dilation. The phenylephrine helped a little bit. Viscoelastic. I should probably speed this up. Actually, it looks like a pretty decent-sized pupil at this point. But even in a situation with floppy iris, it can be deceiving because as soon as you get in and start causing turbulent flow, the pupil is going to shrink down. So a device that's very good, and I use it commonly and hardly ever use iris hooks anymore, is the Malyugin ring. It's easily deployed through a small incision. It's this pretty ingenious device designed by Boris Malyugin with, this is like suture material, like polypropylene, like same material as a thick Prolene suture. So it's flexible and one continuous loop. The newer one is a little easier to unhook. They redesigned the injector. It used to catch a little bit, but you just hook that. Each of those loops, it's a continuous loop, and each loop you just hook on the edge of the pupil. And I think most of you guys have seen this now. It's not new, but it really does save you in many cases. And it might cause little sphincterotomies, little tears, but in general, the pupil will come back to its normal size afterwards. And one thing to note about this, which is kind of not intuitive, let me just see if I can pause it, is you're actually getting 8-point fixation. So not only, if you had 4 iris hooks that might retract here, 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 and here, you're getting, as this loop of suture or loop of material goes from above the pupil to underneath, there's another point of fixation right here between every loop. So there's really 8 points of retraction. This is the same as putting in 8 iris hooks and retracting them all evenly. And it's all without requiring an additional incision. So it's ingenious and a very useful device. High myopia. Watch for staphylomas. They're error-prone axial length measurements. Much better now that we have optical coherence biometry. When we used to use A scans, that was an issue. But the IOL Master or the Lens Star now are doing optical measurements. But it can still be an issue if they can't fixate. Intraoperative concerns in highly myopic patients, soft sclera, deep anterior chambers. You get that hyper deepening. It's a reverse pupillary block where everything gets pushed back. There's an intraoperative maneuver you can use if you do get, I don't have a video of it, but if you do get reverse pupillary block, and you guys have probably, some of you have seen this, as soon as you put your phaco instrument in and turn on the irrigation, the chamber gets suddenly very deep. It's happening because the difference in pressure between the anterior chamber and the posterior chamber is just pushing the lens iris diaphragm back. You can equalize that by just putting an instrument under the edge of the pupil, under the iris, and lifting up. That will let the whole it'll let some of the pressure go posteriorly, and the whole anterior chamber will come back to its normal position. So that's a useful maneuver. But you expect that to happen. And they're at risk for retinal tears. High myopes, especially without a previous posterior vitreous detachment, if you induce a PVD relatively soon after cataract surgery, you're increasing the risk for retinal tears and detachments. Chronic uveitis patients, you want to maintain optimal control, get a quiet eye ahead of time, rule out CME. The old indication was fluorescein angiogram, now it's OCTs. So anybody who you think there's an abnormal macula, get an OCT. We want to make sure they don't have pre-existing CME or epiretinal membranes because you want to treat it, and if you can't get rid of the CME, at least you know it's already there. And epiretinal membrane is a risk factor for post-op CME. So aggressive perioperative oral steroids are helpful in uveitis patients, and acrylic, which we're almost always using now, or the old heparin-coated PMMA lenses may be best, just to keep, because you know these patients are going to have be prone to chronic inflammation. So we want to keep the eye as quiet as possible after surgery. Miscellaneous conditions after scleral buccal procedure. There's an increased axial length, so aim for myopia to avoid a hyperopic surprise. After vitrectomy, expect lack of vitreous support. Posterior capsule is very mobile. There might be zonular weakness. I got burned by that in a case just a couple weeks ago where I didn't know they had a vitrectomy. That was somehow missed, but I found out during surgery. Post-trauma, B scan to evaluate the posterior segment. You guys are pretty good at post-trauma cases. You see a lot of ruptured globes. You want to make sure there's no foreign body or pre-existing RD. If you can't see the posterior pole, always get a B scan. Don't operate on an eye until you know what's going on in the back.
Why do you get a hyperopic surprise you mean if they have the buckle in? Or
Yes, the buckle. They're very often, these patients will, if you aim for plano, you may end up hyperopic. It's just a little bit more because if you're not getting, they tend to have increased axial length or maybe a shortened axial length after surgery. It's patients that have, myopic patients that have scleral buckles, it's harder to hit plano. And, if your error is plus or minus 1, half the time you're going to be above if you're aiming for 0. So aim for -1 and you'll get anywhere from plano to -2. That's mainly the reason. It's a little less predictive. Nobody wants a hyperopic surprise. Patients hate it. So especially a myopic patient. You don't want to make a -5 patient +1. They're much better off -1. Corneal lacerations should be repaired first as a staged procedure and let it heal long enough. If you can wait a little while for the cataract to stabilize the cornea, you'll get better measurements. And expecting problems after trauma, even minor trauma. I always ask patients, patients will say, oh yeah, I was hit in the eye and I had some bleeding and I had to wear a patch for a week and I couldn't see as a kid. Well, that's an eye that you're probably going to have some zonular issues and you can be surprised by it. In fact, and sometimes I found out during surgery, you're operating and there's weak zonules, and then I ask them later, did you get hit in the eye? Oh yeah, I had a car accident or something, I had a fracture. It's amazing the number of people who have had facial trauma and might forget about it when they're older, especially a unilateral cataract. A big clue to potentially a previous trauma is a much denser cataract in one eye. When a patient comes in with a 4+ mature cataract or very dense PSC in one eye and 1+ NS in the other eye, even if they're 80 years old, Ask them more about what might have happened to that eye to cause the cataract. Sometimes they forgot, oh, I had retinal surgery, they had a vitrectomy, that's going to cause a denser cataract. And oftentimes there's some remote history of trauma. And if there is trauma, again, be prepared for problems. Zonular laxity, angle recession causing glaucoma, watch the pressure, and be prepared. Have the tools you need in the OR. I think we get to this, capsule tension rings, and even capsule retractors to support the capsule during your surgery. What is this? What do you think this patient has? That's from the book also. Just yell it out. Anybody? Coloboma, yeah. That's an iris coloboma, and they might have a coloboma in the posterior segment, but when they have an iris coloboma, what are they also more likely to have a coloboma of that worries you as a cataract surgeon? The zonules, right? They have there's missing, not only missing parts of the iris, there's missing zonular fibers in that area. So capsule tension rings are very useful to reinforce up to 3 or 4 clock hours of zonular dialysis. They're best for trauma, Marfans, where there's kind of diffuse weakness, colobomas, where you expect the remaining zonular fibers are more or less normal. If you have very advanced zonular weakness, sometimes like in pseudoexfoliation, yes, you can support them, but if distributing the force from one area to all the others just makes the others rip, then it's not good, and you probably need a sutured lens or some other sutured tension ring. So, or if severe zonular loss, putting in a capsule tension ring is not the way to go. So use caution. I use them a lot in pseudoexfoliation, but not by itself in severe zonular laxity. Putting it in can even tear more zonules than it's worth. So, and there are ways of putting it in that are beyond the scope of this talk, atraumatic methods of insertion, so you don't stress the zonules more. But they're also useful to prevent the post-op capsule phimosis, the fibrosis and shrinkage of the capsule that happens in patients with weak zonules and patients with pseudoexfoliation especially, that can cause progressive zonule loss. If you have that capsule tension ring in there stretching out the bag, it helps resist those forces and distribute the force to all the zonules instead of focally. A weak zonule is like a zipper. A broken zipper, you've all seen if a zipper is broken on a jacket and you have one area that doesn't meet, if you just pull on that, the whole thing unzips. That's what happens to weak zonules too. You have an area of a defect and you start stretching that area. A lot of the force then, instead of being distributed among all the fibers, is distributed just on the 2 end fibers, and this whole gap is not supported. So you start pulling on that area, you'll snap them one by one and just unzip multiple zonules. So you want to distribute the force equally among all of them. This is from phacopearls, a 31 millimeter highly myopic eye with mild phacodenesis seen on gonioscopy, and the CTR is used to stabilize the bag. This is a pretty soft cataract. It's not that dense, and it's not my case, but I did think this video, it shows the CTR insertion without, that's what the capsule tension ring looks like. It has 2 little hoops on the end, and it's a flexible, springy ring of PMMA that's also used for haptics of 3-piece lenses, and you can just dial it in gently. This is a very relatively atraumatic way to put this in. He's not stressing the zonules at all. The final step, just reach in, drop it in, and then you have support. Now, the usual rule of thumb is wait as long as possible to put the CTR in, and I do that. This one was put in right at the beginning, and it worked out. Of course, after hydrodissection, because you're trying to get it into the periphery of the capsule, but if you trap cortex with it, it makes the cortex removal much harder. So I think he skipped a few things, but look how he's stretching the zonules a lot. I think he needed better hydrodissection in this case. But anyway, even in a case with weak zonules, you have good support. So the CTR was put in preoperatively, and everything looks good at the end, as opposed to finding out in the middle of surgery that the zonules are weak and you're stressing them even more. Here's another video of a case where they didn't expect to have zonule weakness, but look, there's a huge zonular dialysis right in the middle of surgery. That's not what you want to see. So you tamponade that with some viscoelastic, use a dispersive viscoelastic to hold the vitreous back. Hopefully there's no vitreous already. Reform the bag, and then insert a capsule tension ring to support that area of zonular loss while you finish the surgery. Nowadays, I mean, this is an injector. It's hard to see because the video is a little grainy, but this is the injector for the CTR. That's what we usually use here. They now have preloaded injectors, too, that the device comes preloaded, but that helps you guide it into the capsular bag. and then proceed with surgery gently. You can see the zonules are weak, and there's some retraction there, but at least it's kept intact. You don't see that area moving in anymore where the dialysis was, and there's no vitreous loss. So it kind of saved the case. Nowadays, we have capsule retractors that I probably would have used on this case, not the CTR at that point, that you can put in like capsule hooks, except they go into the capsule and pull back and hold the capsule in that area while you finish the case, and then put the CTR in before removing the capsule retractors. So, but it's something to know about. What is this? Can you tell? Yeah, lenticonus or posterior polar cataract is what we're trying to show. And they often look like this little bullseye. Posterior polar cataracts are important to identify preoperatively because a posterior capsule defect in that spot is very common. So you want to avoid vigorous hydrodissection in those cases. Preferred technique is gentle hydrodelineation, phaco the nucleus, leave an epinuclear shell, and then maybe visco-dissect the epinucleus or very gently IA. And if you have to leave that central opacity, leave it. You can use a YAG laser on it later if it's visually significant. But be prepared that there might be a zonular weakness there, or a capsule weakness, a defect even. Hypermature cataracts, poor red reflex, difficult visualization. These are challenging cases. We use capsule dye now. These used to be extra caps, planned extra caps. Nobody really does planned extra caps anymore, but even a soft white cataract, when we didn't have capsule dye, there's no way to create a continuous capsulorhexis. And if you don't have a continuous intracapsulotomy or capsulorhexis, phaco surgery is risky because those tears will extend out. So the way to do it is to stain the capsule. Watch for posterior pressure or positive pressure, within the capsular bag. The cortex is swollen. It's a hypermature, intumescent cataract, and the capsulorhexis tends to trend peripherally. So Healon 5 again, or dispersive like Viscoat, and decompress with a 30-gauge needle or the IA tip first is very useful. So here's a hypermature white cataract video from the phacopearls again. Technique is put a bubble of air in, put the trypan blue. Most of you guys, I think, have seen this now. Clear it out with viscoelastic. I like to irrigate it first and then get rid of the viscoelastic. But now that the capsule's stained, it's hard to tell before you make the cut, but once you make the cut, you can see the blue of the capsule contrasting against the white background pretty easily, and it really helps. There's no way to make the capsulorhexis in this cataract without staining the capsule because there's no red reflex. You can't see what you're doing. This makes it almost routine, okay? So you think, okay, that's much easier. Here's another case. And you think, okay, nice stained capsule, here we go. Let's start tearing the capsulotomy, capsulorhexis. But what's happening? Uh-oh. Look, boom. He didn't do anything. He took the forceps out, and it split out. So this is not what you want to see, right? And we've called this the Argentinian flag sign. And that's the Argentinian flag. I've always wondered why. That's the actual Argentinian flag, except this happy sun, smiling sun face is not what you're thinking when the capsule splits out like that. So when you get the Argentinian flag sign, you're not smiling like that. But the point, you can deal with it, but you'd rather avoid it. So avoiding the Argentinian flag sign, use a hyperviscous OVD, such as Healon 5. Decompress the liquid cortex with a 30-gauge needle before starting your capsulorhexis. If you can pull some of that fluid out, you'll decrease the positive pressure within the bag. Pre-treat with IV mannitol. I do this sometimes if you expect, especially a crowded, shallow chamber, a hypermature cataract, you don't want posterior vitreous pressure making things worse. So if you give the patient IV mannitol, you'll dehydrate the vitreous somewhat. Minimize posterior pressure. Check the speculum, head up, no lid squeezing or valsalva. That increases posterior pressure. Don't lose viscoelastic during the capsulorhexis. That case, he probably didn't have you really want to flatten the intercapsule maximally as much as you can, and if you allow the viscoelastic to leak while you're tearing the capsulorhexis, that intercapsule will come up, and when it's up like that, it tends to go out. So if it's flat, it won't go out. And be efficient, move carefully but quickly after the capsule's open, because I think the cortex swells. No one's ever proven this with a study, but if you take too long, once you make that opening, it's actually going to swell. The fluid that is exposed to, the aqueous fluid, starts to, the hypertonic lens starts to absorb aqueous fluid and swell visibly just during the case. So I think that video that you saw where it just spontaneously split out, part of that is the spontaneous swelling of the lens once the capsule's open. So if you can move once, if you're taking too long and you're going very slow, you're allowing that capsule to swell and it'll tear out spontaneously. And those are the ways to avoid it. Sometimes you can't avoid it. You do the case the best you can. But again, you're not putting a lens in the bag, and managing that is beyond the scope of this talk. So we're finished. I know you guys asked questions during the talk, but if there's anything else you're curious about, I mean, this is a procedure I do every day, so there's not a lot of science in cataract surgery. It's a little more practical, hands-on. So it's something you don't want to talk about as much as you'd rather do it. You know, the experience and doing. That's why we watch video. See trouble that other people get in and get out of. Watch as many cases as you can. Experience complicated cases for yourself. That's much better preparation than us sitting here talking theory about cataract surgery. But is there any questions anybody else has? Okay, well, we're done. Thanks. We'll see you in the OR. All right.